There is some difference between Europe and North America in the type of imaging used. Predominantly, CT is preferred in Europe over TE, whereas in US, TE is preferred over T is preferred over CT. This is changing slowly. As seen here, aortography and MRI are used in very few patients. The sensitivity of these tests are excellent, except for aortogram, which is likely to miss many cases. Otherwise, the CTT and MRI, the performances are very good, especially in good centers. This is a single center study. And the specificity is also very high in diagnosing acute aortic dissection by any of these imaging modality. However, when you go in real life, the sensitivity is slightly lower than what you see in a single center observation. As you can see, these are no longer in the high 90s, but rather in the low 90s and 88% there. This is the trend in utilization of different imaging modalities that we see. T has been declining and CT use has been increasing, and clearly MRI and angiography use are on decline in the diagnosis of acute aortic dissection. Most of the diagnosis of aortic dissection is based on imaging studies. There's been a lot of work now ongoing to identify biomarkers, and these are the markers that have been evaluated in small studies. I can tell you none of them are ready for prime time. The early markers that have been identified are D-dimer and HSCRP. And in the first 6 hours, smooth muscle myosin heavy chain. In the next 6 to 12 hours, it's calponin, all the smooth muscle troponin, CKBB, which is a brain-related creatinine kinase, and TGF-beta 1. Also, these are markers that are elevated between 6 to 12 hours. And later on, to follow these people, you can, the markers that have been used is MMP9 and the ratio of TIMP, which is tissue inhibitor of metalloproteinases to MMP9. So there is a lot of work ongoing to see later on as follow which patients develop aneurysm expansion as well as dissection. Can we predict that? And these are these various markers related to where they come from. So, for example, TGF-beta 1 comes from regulatory proteins. The smooth muscle cells, these markers, calponin, the myosin heavy chain, and CKBB comes from them. CRP is the inflammatory marker. Then there are endothelial markers, which are fibrillin, elastin degradation product, MMP, and collagen, and then the clotting factor or endothelial markers like D-dimer, von Willebrand factor, or thermomodulin. And this is their timeline where it arises. D-dimer, as you can see, is high to begin with and then slowly declines after 12 hours. The calponin levels are not detectable, but starts increasing around 6 hours or so. The smooth muscle myosin heavy chain is elevated very early, but after 6 hours loses its sensitivity and specificity. And the TGF-beta, peaks around 6 hours, continue, and it's non-detectable at 12 hours. This is the data, the first paper published on D-dimer, and what it showed was that sensitivity is excellent. So every patient with acute aortic dissection had early rise in D-dimer. And this is important because we use D-dimer to rule out pulmonary embolism in ER, but we forget that if the D-dimer is negative, the negative predictive value for D-dimer is pretty high for detection of aortic dissection. So if your D-dimers are normal, then it's unlikely that this patient has acute aortic dissection, leave alone pulmonary embolism. Specificity is extremely low. The levels are related to the extent of the disease as shown here. So people with thoracic have the least and thoracoabdominal iliac involvement have the highest level of D-dimer. And there is an inverse correlation between the absolute value and time from onset. So the highest values are close to where the dissection occurs and then it tapers off. This is summary of all studies and it shows the same thing, 97% sensitivity, specificity is extremely low, varying from 34% to 81%, around 50 or so percent. So D-dimer testing has a high sensitivity and negative predictive value, but low specificity and positive predictive value with when we use a cutoff which we normally use as 0.5 microgram per ml. And the absolute degree of D-dimer elevation may reflect the anatomic extent of the dissection. So the higher the value, the more extensive is the dissection. CRP level tested in very small study, you can see that they are being an acute inflammatory marker. They are high in patients with acute aortic dissection. CKBB was again tested in one small study by Suzuki et al. And published in Lancet, and you can see that levels of CKBB tested drawn at around 6 hours and 12 hours were higher in patients with aortic dissections compared with healthy volunteers. This is the enzyme that has drawn the most attention, again tested by Suzuki et al. This is the SMMHC, which is the smooth muscle myosin heavy chain. But the biggest disadvantage is that it's highest in the first 6 hours, but after 6 hours it returns to baseline very quickly. And because this is a smooth muscle disease of intestine as well as uterine diseases, as well as if people have had a cath, and then these values are high for these patients. As shown here, the highest levels are in less than 3 hours. Then, as time goes, the value declines, and these are then after 12 hours are not detectable. Again, the same data, but showing this time that the levels are much higher in patients with type A dissection compared with type 2 dissection, although the trend, the temporal trend for rise and fall is the same for both types. So levels of smooth muscle myosin heavy chain protein may be used to diagnose acute aortic dissection soon after symptom onset. However, they decline in their sensitivity as time goes on. The assay appears to have the greatest diagnostic value in patients with proximal lesion rather than descending aortic lesion. This is another marker, as you can see, SELF or the elastin fibrin degradation product. And they again here in untreated aortic dissection, those values are very high. This is being tested now in several single center studies. These are the calponin. There are 3 types of calponin that's been tested. One is the acidic, the basic. Both acidic and basic form have similar kind of predictive value. The neutral calponin really has not been found to be useful. And what they show is that there is a rise in about 6 hours, and then by 12 to 24 hours it normalizes. and the pattern is same whether you take type A or type B. There is a rise in 6 to 12 hours and then returns to baseline within 24 hours. This is the TGF beta 1, again shown that compared to controls, TGF beta 1 are very high in patients with aortic dissection, and that treatment with losartan and beta blocker leads to decrease in the level by decreasing the tear of these vessels. And levels are typically higher in female compared to male, both normal as well as in patients with dissection. And the levels are much higher in type A dissection compared with type 2 dissection. MMP levels, this was done in acute aortic dissection. However, most of the work now is focused on following patients with aortic dissection long term, because this MMP rise related to baseline allows us to detect expansion of aortic aneurysm much before you can identify with imaging or other modalities. So then coming to the prognosis, mortality as shown here is pretty high and increases with time unless it's treated aggressively up front. And medically treated patients have worse mortality than surgically. Obviously, this is biased data given that the selection was not randomized. But the most important message is here that if you survive the first 30 days, your long-term outcome is very similar. This is very similar to any cardiovascular acute disease that we see, i.e. cardiogenic shock, acute MI and stuff, because the later outcomes beyond the acute phase is decided by the comorbid conditions rather than by the disease itself. More and more patients are being offered surgical treatment now, and very few patients get now medical therapy. This is again data from IRED. And whether it's a result of that or improved treatment, mortality is on decline when IRED data was looked in this quintiles of enrollment. But the problem still remains after discharge. Here is the data published in Journal of Cardiac Surgery. 148 patients with type A acute aortic dissection, mortality in 22%. But among 115 survivors, 48 people, or more than 40%, required reoperation for various reasons, i.e. aneurysm, dissection, aortic valve replacement. So surveillance is very, very important once you diagnose aortic or treat aortic dissection and discharge them from the hospital. There are various models available to predict risk, short-term as well as long-term. This is one that we published in CIRC many years ago. And basically, we derived a score which was then validated later on in the same data set and is helpful in kind of counseling patient and estimating the risk of patients undergoing aortic aneurysm surgery as well as medical treatment. Age, like any other factors, has some implications. So older people, as shown here, are more likely to die than younger people, particularly in the medical therapy group. So whether you are young or old, if you are treated medically, you are more likely to die. Surgical treatment is associated with better outcomes in both elderly as well as in younger people. And the risk does play part in, there is a risk with age interaction in the sense that if the risk is low, it doesn't matter if you are old or young, your outcomes are similar. It's in the high risk population where you see that the mortality is much higher in older patients compared to the younger people. Cardiac tamponade is associated with significantly worse outcome, double the mortality, and when people have cardiac tamponade with aortic dissection, ideally they should not be drained at bedside, they should be drained in OR because this has been shown to be associated with very high mortality. Hypotension and shock, again the same story, very, very high mortality, whether you have type A or B. If you have shock or hypotension, you die very quickly, and the mortality is extremely high. Whereas without shock, the patients are more likely to survive. And whether you look at younger people or older people, shock seems to have the same kind of prognostic implication associated with significant high mortality in any age group. This is another very important prognostic marker. We seldom do it, identifying the number of compromised blood vessels. And we looked at this at 0, 1, 2, and greater than equal to 3. And we found that there was a trend in increase in mortality, in hospital mortality, as the number of pulse deficit increased. Again, given it's intuitive given that this tells us the extent of dissection. But the most important thing is here, the more pulse deficit you have, the more early you are likely to die. So your mortality is very high very early as your number of pulse deficit increases. Renal insufficiency at baseline again was associated with doubling of mortality in IRAD, and it's a very important prognostic marker. So how do we treat and follow these people? Treatment, basically initial medical stabilization is important. Acute surgery is the key in type A dissection. Most people don't survive if you don't take them to the OR. Fenestration of if malperfusion is present is important to stabilize patients. What I mean by that is if somebody comes with a stroke or has mesenteric ischemia, or if they have renal failure, then creating channels by fenestration between the false and the true lumen in the dissection flap allows to restore the flow, stabilize the patient, and improve outcomes in the short and long term. And the long-term surveillance, as I said, is very important because of the increased risk of recurrent dissection or aneurysm in this group, and patient education as to the activity and goals for prevention is also important. So what is important about medical management? Basically heart rate, blood pressure control with beta blockers, class 1 indication. If beta blockers are contraindicated, non-dihydropyridines, calcium channel blockers should be utilized. And the target blood pressure should be 120/80 as per this guideline recommendation published in 2010 in JACC. Class 3 indication is vasodilator therapy should not be initiated prior to rate control, so as to avoid reflex tachycardia. This is the only class 3 recommendation. Surgical management should be considered for all patients diagnosed with acute aortic dissection, more so with type A than with type B dissection. And then it says it is reasonable to treat intramural hematoma similar to aortic dissection in the corresponding segment of aorta. So if there's an ascending aortic intramural hematoma, it should be treated with surgery, and if it's descending, managed conservatively. Long-term goals are addressed here as beta blocker therapy to heart rate less than 60, blood pressure control to 120/80. Some small studies suggesting that ARBs are better than beta blocker and ACE when you are treating Marfan's and other connective tissue disease that are inherited. Statins for atherosclerosis, anticoagulants have no role. And then this is a class 1 recommendation from the guidelines, which says that once you have fixed them, you have to repeat an imaging study 1, 3, 6, and 12 months from the start, and then if they are stable, annually thereafter. And then education of patient that this disease is lifelong, to educate them on the symptoms, restriction of activity, especially reducing isotonic exercises, and then compliance with medications and follow-up. The major class 2A recommendations for follow-up is CT, as I said, CT 1, 3, 6, and 12 months, and then if stable, annually thereafter. This is considered class 2A recommendations by the guidelines. And then finally, a word on the management and counseling of patients with aortic dissection or who are at risk of aortic dissection during pregnancy. Women with Marfan syndrome or other inherited aortic disease should not be only counseled about the risk of aortic dissection, but also that because they are autosomally inherited disorder, that the likelihood of their offsprings getting these syndromes is pretty high. If they have known aortic dilation, then they should be treated aggressively, and blood pressure should be controlled aggressively, best drugs being beta blocker in that stage. For people who have known aortic root or ascending aortic dilation, echocardiography bi-monthly or even monthly should be performed. As far as the imaging is concerned, they recommend that instead of CT, which is a lot of radiation, MRI or TE are preferred for pregnant women. And then class 2A recommendation is that fetal delivery via C-section is reasonable for patients who have sufficient aortic enlargement, previous dissection, or severe aortic valve regurgitation. So these are some of the recommendations for patients who are at risk or with aortic dissection in pregnancy. And this is where the field is moving. The field is moving to identify acute markers, identify more genetic predisposition accurately. And then we are moving from static imaging to dynamic imaging. I don't have, I deleted that video because it was occupying a lot of things. But you can actually do this CT on these people over time and superimpose them on them so that you can see where the expansion is actually occurring in these people. And so this will allow us to better follow the patients over time. So in conclusion, aortic dissection is rare. Typical symptoms of chest pain may not always be present, so high index of suspicion is necessary, particularly for those people presenting with a stroke, CVA, or acute heart failure, and in older people. Imaging modality currently remains the mainstay of diagnosis, but biomarkers are in evolution, but they are not there. Still, a lot of work needs to be done for them to be routinely available or used. Information, a lot of information is available on prognostication, and this allows patient counseling about their risk. Surgery remains the mainstay of treatment, and delay is harmful, so everyone should get a surgical consult as soon as possible. And lifelong treatment with beta blocker or other blood pressure reducing agents and surveillance important, as subsequent event rates are very high. Thank you for your time and attention.
Any questions?
Raj, that was great, thanks. There's been
People have worked on developing regional systems of care to treat aortic dissection faster. Do we have, what's the evidence behind faster time to surgery results in better outcome, and that regional systems to streamline getting to the OR quickly improve outcome?
So there is a lot of data that suggests the earlier treatment is better because the mortality is very high. It's 1 to 2% per hour of time that's lost. Having said that, in IRAD, the median time to treatment was 48 hours. So not everybody goes to surgery quickly. There are many reasons for it, because patients present to the nearest hospital, there's a delay in diagnosis. Then those hospital decides A, patient is very sick, so it's worthless sending them, or B, is stable, send them in, or send them in anyway. So there is this effort to develop regional care, and as you can imagine, this is a disease which is very low stake, unlike the MI and stuff. So it hasn't been very successful because people are taken to the nearest hospital, and then the hospital decides. There are no regional systems that I am aware of that has like the MI programs that are in place.
Raj, that was great. I may have missed it. The general trends in the U.S. for atherosclerotic cardiovascular disease have been improving, but hypertension, diabetes, other comorbid conditions are increasing. What's happening with the prevalence of aortic dissection?
So as I told you, it's very hard to determine the prevalence of it unless you, and in fact there is only one study that I showed you from UK that was just recently published that tells us that prevalence is somewhere about 6 per million patients per year, something that low. We don't have any information on what's happening to the trend of acute aortic dissection. We do have information on the fact that mortality related to dissection is decreasing with improvement in treatment, and people recognizing that surgery, no matter how sick the person is going to save lives, not medical treatment or initial stabilization.
Great, thank you. All right, well, thank you for a wonderful research conference, and have a good summer.